Hi, everybody. It's Kevin and it's Donna, and we're so excited to have you guys for another episode of The Med List. Today, Donna, we've got a special guest with some
Mhm.
really incredible background and experience coming into pharmacy and a lot to celebrate, when it comes to being a pioneer in several kind of settings throughout her career. So excited for that piece. Other things I'm excited about is the NCAA tournament is coming up, and my Cougs made it, right? It's been 15
Oh,
years.
there
So
you
this
go.
is all about seeing some WSU make it onto the big stage. Are
There
you
you
going to
go.
watch March Madness?
Yeah, so my daughter is a Jayhawk, so sometimes they
Oh,
get some cheer
wow.
from here. So yeah, but yeah, I'm waiting for the poll, the whole squares to come out. So I know that there's already some squares out, but the one I go into, we're waiting for it later this week.
Okay, you get those brackets together. We'll have to talk to Ahunna a little bit about having a pharmacy and or healthcare bracket buster here put together sometime soon and talk about healthcare madness. And we'll start that right after this. Yeah, it's one of my favorite times of year, Donna. Like the weather is getting beautiful outside. I've got great basketball to watch. I've got two little guys at home that are able to run outside and enjoy life. And I think that's one really neat thing, just the diversity of being able to enjoy things during this spring season. Little things are coming up and changing and new. And I think Ahunna is all about that. Like there's little things in her life that are new and changing and hopefully changing the way we talk about healthcare. But without
Yeah.
further ado, I'll bring her aboard so we can introduce her.
Yes, hello. Thank you for joining us. So,
Oh.
um, today we have Dr. Ahunna Freeman, and she is a Nigerian American, and she first got a degree in chemistry. So I loved just reading that. I and then went on to pharmacy school, which I did that too. So, and you have your Doctor of Pharmacy degree at Campbell University College of Pharmacy and Health Sciences. And you began your career as when I was reading all about you, and I was like, oh my gosh, this is like exactly big box retail, right? And then you start to diversify and you just fell in love with the whole problem solving. And that's what we really do as pharmacists. We sleuth quite a bit. So, and you're an expert in this, I have to say. You actually opened a pharmacy with your husband, Southside Discount Pharmacy, and now you're a pharmacy owner, preceptor, and entrepreneur in this area. And you also are the president of Aligned Care LLC, which is a healthcare company that endorses a team based approach to patient care and community practices. And I just think that this is so outside the box of what we typically hear our retail pharmacists and even independent pharmacists doing. So, hats off to you for all of this great work that you're doing. I'll let you tell us more about your companies and share with us just how you landed in doing all of this.
Well, I obviously didn't fall off the sky. I'm from Nigeria, like you mentioned, and I ended up here in my community here because I did my last year, fourth year rotation at in this area, you know. And since then, I just never left. So yes, my career in pharmacy started off in the big box chain. You know, it served a big purpose in my life at the time.
Wow.
I started having kids, and it was harder, trying to hold on to those type of hours and work like I was working prior to kids. And I just needed more because I wasn't really fulfilling like what my patients were needing. I didn't have much time with my patients that needed help, had questions. I couldn't just really help them because it was always going, going, going and not stopping. And I just knew, okay, we had to do something about this. And of course, that's when we started thinking about independent pharmacy ownership. And it happened. I didn't think it was something that I would ever do when I was in pharmacy school, but prayers and having that little faith and just taking the leap. And almost 10 years, here we are.
Oh my goodness.
I
That's so
know.
exciting.
Well,
But
Yeah,
yeah,
the one thing I was going to ask you, Ahunna, about that leap that you took, one, what things did you see that were missing in your previous pharmacy roles that you wanted to introduce into this pharmacy endeavor? And you mentioned community. That's always an interesting thing for me is why did you choose the location that you chose? You know, what was it about that community to serve that area and those folks?
Honestly, a lot was missing, but just to the clear goal I had going in was to build a community pharmacy that's more of a clinical community pharmacy. And with that, like I wanted patients, I wanted the people in that community to make sure that they really understood whatever they needed to know about taking care of themselves or preventing to need all the medications that we're piling on them, right? Because
Mhm.
honestly, if they don't know that, how would they be able to do better? We all learned, so it was only fair that I was teaching it. And another thing is the community itself. I honestly didn't really understand how diverse it was until we were further along, because it's a big diverse community with Spanish speaking, English speaking. So, and I don't speak Spanish, so it was a matter of also adapting and building trust, not only by my profession, but like with a language that I know nothing about.
Yeah.
So always having a translator was a big help, but being able to also speak to my patient and like feel my patients and really have them understand me was a big difference from where I was. So that's also one of the things that make me love the community I'm in right now, because they've just as much as I ask for them to trust what we do every day,
Yeah.
they're also I'm also like I'm trusting, like they're trusting me that I'm also helping them like I should, like a family. So
That's beautiful.
it comes down to it's just a two-way street. And that route also helps me advocate for them. And when you're advocating for your patient, quickly you realize that you're sharing these patients with other healthcare providers. So then I found that I had to also build relationship with those other providers, because after all, we have these patients in common, so we might as well just be friends. And that's how my consulting business came about. That's how I actually get that idea in my head and just decided on doing that. And it didn't require any capital, so like a pharmacy. So that's how that came about.
Yeah.
Wow. Yeah, the one thing, Donna, I'm sure that caught your ears too when you heard Ahunna say it, but you said you wanted to be able to feel, right, what your patients were going through.
Yes.
Give me a little bit of your soul on that one, Ahunna. Like, what does that mean to you, you know, to connect with human beings like that on a deeper level? Because I think I mean, the show is called The Med List, right? But we know that it's so much deeper, like the human connections and knowing what people want is so meaningful to truly practicing medicine in an appropriate way.
Yeah.
What does that mean to you, and what did you learn along the way with those lessons you talked about?
Honestly, I think I'm learning more than I really wanted to and bargained for, because each time I always tell myself, I cannot get too caught up in this. I can't get too involved, but as human beings, like you can't sit back and see certain things happening,
Amen.
and and knowing that you could, even if you can't help, like you have to put the effort to provide a resource to help. And when your patients are very open to you and tell you what they're going through, things that we take for granted, whether it's an illness of a spouse or a family member, a parent, it makes it harder to just care for just that patient and keep it moving. Like you can't do that, because now you want to know how they're doing, how their other people are doing, and how they're dealing with the situation. I had a
Mhm.
patient just last week actually just tell me, I just haven't been using my insulin just because I can't. I'm like, okay, well, it's zero copay. You should have enough. Like, why? And it's just because she goes through these bouts of depression.
Yeah.
And right. And it's not easy for a patient to just tell you that. She wasn't in the pharmacy to tell me about her depression.
Right.
But we're talking about diabetes, we're talking about insulin use, we're talking about medication. But here she is telling me more of her mental health that needed to be tended for, right? Before she could do any of those,
Mhm.
right? And it's not
Mhm.
like it's not a financial problem, but it's just something more deeper that I had to then definitely, that's the connection that when you build those type of connection with your patients, it's something that I didn't quite get, and I didn't prepare myself like I was going to get that deep, right?
Wow.
Yeah.
Now it's just part of what we do here.
Absolutely. But so good of you to take the time to listen to people, and that you've developed such an environment that people feel that you have the few moments or even more than that to spend with them. So that's wonderful. It kind of takes me back to when I first started off in pharmacy, and it wasn't so crazy and it was enjoyable, and you really got to know your patients really well.
Right.
And I treasured that time as well, Ahunna. So I can appreciate what you're doing and those connections you're making. One thing I wanted to ask you about is you mentioned that you have some other like non-dispensing services, and that might seem rather strange to maybe some of our clinicians and even patients or caregivers who are listening. And I think a lot of people think about, oh, they're going to the pharmacy, pick up their prescriptions and go, like it's just one of the errands along the way. But
Right.
you have so many different areas that you concentrate on, in things such as like hormonal consultations and point of care tests. And you talked about having that translation service and education. So I would love for you to tell us more about those programs that you have, or how you use that to both the patient and the clinician benefits.
Oh yeah, I always say that pharmacy really is just, it's kind of like when you walk into a stage, a theater, and you pay for the entrance. You don't know if you could be watching a dancer, you could be watching an artist um, playing an instrument, like whatever it is, but it's a stage. And I think that's how pharmacy, it gives us that platform to perform. And it doesn't matter how we're performing as long as it's within the scope of our practice, but we're not entertaining the audience, but we're performing for our patients. And sometimes we're also performing to complement the work of other providers, right? Right. So for us here, and that was one of the things, that's when I say a clinical community pharmacy that I wanted to build, the vision I had was just to be able to have those opportunities and those options for the community. Because if they're not able to get that anywhere else that's around them, they can get that here. So for the hormonal consultation, most of the places are open normal business hours, 8 to 5, right? But how about my patients that rely on a spouse that by the morning time they've gone on to work and they don't get back till like 7? That patient is at home. They can't make those appointments. They can't get to those appointments. And not just that, they probably don't even trust the means of getting to those appointments, because now they also have to worry when they get to the appointment, will there be the translation services? Are they going to be understood? Would they hear them? Things like that. So when North Carolina was able to offer that opportunity to us to provide those services, I absolutely had to take advantage of that. So I did that so I can bring it to my community. And it's not a service, most people would love to use it, but the limitation to it is the cost. Of course, they want the insurance to cover it. We're making progress in that in North Carolina with Medicaid, right? But so far that we've used it, it's been just cash pay, right? And those are the people that cannot get to those appointments. Those are the people that really, they come on Saturdays because that's the only time when their spouse or whoever is not working that they can bring them.
Right.
So it's something that they know that they can take care of and don't have to worry about, how they're going to get to the appointment, just to have some kind of birth control, right? And then we have point of care tests. We started our point of care testing services way before COVID. And the only reason, right, it all started with hemoglobin A1C testing, really. And it was because of the prediabetes education, the prediabetes education that we're doing, or diabetes prevention program that we were doing. We no longer do that now because it's a year long, it's too long. But that's how we started that. And, um, we started offering it to the community, and I quickly was realizing that people, they don't really trust the pharmaceutical company, or they don't trust. How many times like they go in and you tell you, oh, you have prediabetes or you're at the borderline, we're going to start you with metformin. Like, oh, I don't want the medicine. Like, is there something I can do? I'm going to start working. I'm going to start doing better. But then how do I check my progress? Right. So how do I check my progress without breaking the bank? Right. Or finding a provider, because they may not even have a primary care provider. So just being able to offer that too, on a whim whenever they want, is something that we do. Point of care test, just glucose testing. Sometimes they just don't. They seek help. People might seek help when they suspect that something is off. They're not feeling good. They're feeling dizzy. They don't know why. So they just want, anything you can help me with, because they don't want to go rack up that bill in the urgent care, and they don't want to go sit in the ER for however long, right? And they don't want to miss work. Right. So if they're really ill, they're going to have to miss work. That means they're going to be behind on their bills. So the big point of care testing that we can do to just rule out things like, okay, this look good, or like, depending on how they're presenting, you absolutely just have to make that appointment, or you have to go to ER. Sometimes I share some of those stories on LinkedIn too. But yeah, so
that hub model, Ahunna, is just so encouraging to me. For years, like public libraries, have been a dying thing that no one thinks are going to exist for a really long time. And they're still around, and there are some that are actually thriving. Interestingly, one of the reasons why, like the one in Spokane, is doing so well is they're a recording studio. They help you out with video and video casting. They're helping you with, writing and coding and learning. They're helping you with business development, like things that you would think are related to learning processes that are now being leveraged by the professionals who are already working in those library settings, is a reason why a model that looked like it was just giving out books, just like a lot of folks may think a pharmacy is just giving out medications, has evolved in order to stay relevant, in today's times. But the one thing that's kind of interesting there is a lot of it is based on a subscription model or a taxpayer model, within the library systems. But in the pharmacy system, we don't have that luxury in the United States, right? We still have a payment model that is oftentimes fee-for-service based. And you did mention that payment, is one of the things that you've struggled with when it comes to Medicare, Medicaid types of billing. So my next question is really something that I think is really innovative that I want to make sure highlighted for patients is Ahunna has relationships she mentioned earlier on that were so important because she shared care with other providers in her community. So why not be friends, as Ahunna said, which I think is a genius way to say that. Like, that is marketing genius.
Friends, to be exact.
Yeah, exactly. And so with that, how are you able to connect that divide? Because I'm sure a lot of folks are thinking, well, I have my pharmacist, might be at a retail chain store or independent, whatever the case may be, and I ask them a couple questions here and there, and I've got my primary care provider, and I'm assuming that they're talking, in the background, which isn't the case oftentimes. So how did you find that model that you were able to unite those things together and be able to solve for the cost equation? How did you get that all to work, Ahunna, and why is that so exciting for pharmacy today?
Honestly, it's just, I think it's when you have the same problems over and over, and you just find out, okay, you have to at least find a solution. And then if it works multiple times, then you just kind of replicate. And that's how that had fallen on my lap, seriously. And it's not always, it doesn't always work out for all patient and all provider, because there's just some that would rather keep off, and just only focus on the patients. And there's some pharmacists like that too. But I think it starts with building the relationship with your patients, because with that, the patient will feel that they're being heard and they can share more with you. And based on what they share, that's when you reach to their provider and share the same, because that's what we're supposed to be doing to the benefit of these patients. And from then on, not just to leave the message there, you have to also follow up with that. Like, I just wanted to know what happened with this. I'm just checking in and following up with that provider's office, because a lot of times at that time, that provider's office would think, most people don't usually do this. Like, they always send the fax or send the message and just, but, and I think how you also deliver the message is what makes a difference, because we're not here to point fingers or to put blame. We should really all be on the same team. So learning how to craft those messages, delivering it in the right way that's polite and very respectful for all parties, and following through with what you say you would actually do, whether it's what you would do for the patient or what you would do for the provider. Because I understand it's just free work, free service, right? But you cannot get to where you want to be without testing what you want to sell.
Yeah.
Right. So you start with the free work, and that's how it started. And once it's accepted by the providers, you just multiply the same for every other patient, and build your relationships with these clinics and these providers.
That's great. So, Ahunna, I want to ask you a little bit about, because we are the med list. I love to learn about, so how are you in your pharmacy changing someone's med list, shall we say, so that it sounds, you're caring obviously for your patients, and it's not a numbers game necessarily. It really is the patient first, from what I'm hearing and understanding, and can feel from you that it is definitely the patients first. So with all of these things that we talked about, and all of your services that you have, how is it? And I love that you also have on your LinkedIn that you're a fierce patient advocate. Love that. Um, so how is it that you might be changing the med list, and how are you working with providers for the healthcare professionals in order to do that, and or the patients, and how you're doing that?
Well, how am I changing the med list? With each patient, I try to see beyond what their med list looks like, right? Like, I try to connect the patient with their core, not just their med list or like the type of drugs they have. But see, this life is messing me up.
No, that's fair. I mean, it's complicated. Like, just what do you start with in general? I'm really curious, Donna. Ahunna, are you feeling like you're getting questions on, Ahunna, my pharmacist, my trusted advocate, I need help with reducing the costs of my medications, or I'm having a side effect related to my medications that I'd like to be able to mitigate, or they're too complex in general, and can you streamline them down? Is it coming from the patient side asking you for specific help, or is it coming from your side going, this regimen has issues, like inside of this list, I'd like to help this patient to be able to make this a better, more workable solution for them and their provider? Like, where are you coming from usually? Which angles?
It's actually most of the time it's coming from our angle, because I think with a lot of times, if it's not initiated, the patients really do believe that this is what it is for me. This is where this is where I am, and this is what it's become. Right? I should have done better when they told me to do better. Blah blah blah, all that stuff. So we have to learn to initiate those conversations, and then ask deeper questions on, are you feeling any side effects, or are you having problems affording this? Like, we should be looking more into like that with that particular patient. What is it, along with the other medications that they have, that could be not working together? If a patient comes in with 20 medications on their drug list, that's already a red flag, right? Because it's always about simplifying that process for them. Do they really need all of this? So that's where we start. Which ones can be gone, and how do you feel about dropping some of these, or reducing the dose on X, Y, and Z? Or even if you're taking this, how do you know that it's working? Like, are you just throwing towel and waiting for that next appointment in 3 months to see if it's working? Like, what are you doing on your own to see how it's working? And I think based on that, their response, that's how it kind of guides us, or should guide us as pharmacists, on the next step to take. So if the patient has the desire to minimize the drugs, now we really have to think of deprescribing. and we have to get everyone on board because you just can't do it with the patient alone.
Yeah. So on your whole provider side and with Align, do you also get questions through your providers that are asking you not only about, say, drug interactions or various things like that, or change of therapies and what might be best for this patient, but what about, are you having to say, oh, this person's is on 20 meds, or are they going, oh, this person's on 20 meds, could we do a med review together or something?
No, on that end, honestly, they reach out with specific question, and it might just be like, "Oh, can you tell me a little more about like what are my options with this situation or this scenario, or this patient? I have a patient that is taking X, Y, and it may not even be my patient. It may just be their patient in their own practice, but when it comes to medication expertise, like who am I going to turn to? Because let me see who my resources are and just run this by them. And maybe we can figure it out together. Sure, there's a guideline. Everyone has got the app of their guide. They can look it up and figure out, okay, this patient should be on this. But who is it that thinks with that expertise that can cross all the T's and dot all the I's? That's what you're offering. That's what I'm offering in that service. And whatever the solution might be what they're already thinking, but at least it gives them just the perspective from a pharmacist corner perspective to make a better clinical decision for their own patients. So yeah, on the clinician side, a lot of times it's coming from the clinician themselves. They have to be able to reach out to ask those questions, but it starts with you first, building a relationship for them to feel that way to reach out to you.
That's so helpful. I saw a post, and in fact, I even connected with your colleague that mentioned you there, Ahunna, and that was, I'm going to give him a shout out. Where is his name? Joshua Engel, looks like. Did I pronounce that correctly? He's a primary care physician, but he mentioned Ahunna specifically in a recent post talking about when you're in a healthcare system, right, in a hospital system, you have a check and balance kind of thing that Don and I have appreciated through our hospital careers of you're working hand in hand. Physicians and pharmacists are able just to say, that's not my world of expertise. I'm going to pass this along. But as soon as you go out into the primary care world, as Josh mentions, that's not the case. You're on your own to a certain extent. And you don't have that trusted colleague, medication expert next to you. And so he really commends you on being able to be that. The one thing that I'm really curious on, because you mentioned it here, Ahunna, is you talked about guidelines, right? The one interesting thing about guidelines is when we first started practicing, all of us, let's say 10 years ago, just to make it a little bit earlier in space. 10 years ago, we were seeing updates and changes to guidelines. They're like every 5 years, right? And we were seeing like 5-year, 3-year cycles for most guidelines that come out. Now we have literature that is moving at absolute light speed that is difficult for anyone to keep track of. Do you feel like that is something, Ahunna? Because I know that Don and I have shared stories offline about the same thing, that we're talking to our practitioner colleagues about things that we're encountering in literature and saying, did you see this? Is this something that we're going to change to our formula or our practice? And even those folks that are highly informed specialists are still saying, oh, I didn't see that. I've got to read that, and get a better idea of how we need to change patient care. Is that something, those epiphany moments for your primary care providers, something else that you've seen?
Yes. I mean, you're right on point with that. And in this day and age, they're happening, like the changes happening like that. And not just that, to me personally, I've always, in pharmacy school, we always learn the guidelines and then the updates. The trick with me to keeping up with that and keeping up with life as it is being a preceptor. I'll be honest, right? Yeah. Because when those guidelines are updating and changing, they're learning it currently, right? So discussing or having discussions, conversation with whatever condition it is, they're already fresh, with the knowledge compared to myself, right? So it kind of helps me as a pharmacist to also stay on top of that. And even at that, I don't 100% all the time sit on the guidelines as in that's the only way, because I see it as just a template. It's a guide, and everyone is different. Every patient, every situation and scenario is different. So that's something we as providers or even clinicians needs to keep in mind, because what works for one person doesn't always have to work for the other, even though the guideline says that you should. But is that the medication, is it supposed to help or is it supposed to harm? That's
True.
something we see, and that's one of the things. If you also saw in my newest my modules that I just created, those are one of the things I mentioned, because they're spitting out these drugs, like newer drugs every day. And if the drug rep is not coming through to introduce you to those drugs, like how are you supposed to keep up? And not because the introduction is done, but it could also be biased, and it may not be feasible for your patient to be on that newest drug, but at least knowing that it's available is something like clinicians should also keep up with. And it's not always easy to do that.
So, Ahunna and Kevin, just to add to this conversation in regards to guidelines changing, and we're also talking about affordability, the new guidelines for heart failure are very different in regards to the 4 pillars that they are now wanting folks to use. And there's a uptick in expense because a couple of the medications out of these 4 pillars are brand only. So when we're looking at this and trying to help patients aren't used to paying high priced meds for heart failure. So are we switching people? Are we keeping them where they're at and just new heart failure folks are we trying to do this for? So I find that is really quite a stage that we need to really try to figure out and pivot for folks. How are you doing? Do you need this? Should you be on the 4 pillars as quick as we possibly can? And can you afford it?
Right.
It's really incredible. So I think it's so important that we're looking at all of these factors, and is it right for the patient? Is it affordable for the patient to sustain it?
Right. And the sustainability it's a big, I mean, it should be factored into every decision, because there's always a way to initiate the treatment with whatever newer drug out there, but also sometimes it takes the additional step to go looking for those ways to initiate the treatment,
Mhm.
right? And again, that's why a pharmacist insider is good to know.
Mhm.
But in some cases, there's no way. And in some cases, even if there's a way, the provider might not be aware of the
Mhm.
options. So just starting the patient on that alone, but while the patient is started on it, to also have plans on how to sustain it if it actually is beneficial for the patient. And if
Right.
it's not, what is the next plan? Like, what's the plan B? And
Well, yeah. Go ahead.
no, but those are really hard, especially when a clinician can only see a patient for like 15 minutes. Like, you have this 15 minutes or 30 minutes, and you can't really get all those done, reasonably. So now what are your options?
Right. And also with the guidelines, they don't cover everybody either. And I think we have to think about that, especially with our aging population, is a lot of the guidelines just kind of end or trail off as people age. So 65, 75, 85, we might not know what to do with these folks anymore, right?
Right.
And the guidelines don't share with us what to do. And it's really that evidence base that our healthcare is actually comfortable with, right? And they want to stick with this evidence-based medicine for litigation purposes, et cetera.
Right.
So when we're looking at that, and then we're looking at our older adults, not only are we thinking about, how long have you actually been on this medication for, and your body has changed, and how do we stop? How do we deprescribe, and when do we deprescribe? And as you know, that's the part I absolutely love. So, but working with people and guiding them, and then also the providers to change that thought process that yeah, great benefit for years on this drug, but it's not benefiting you anymore. So
Right.
just like a new initiated medication, we also have to be continually looking at the meds, and is it still a benefit or not? And should we initiate deprescribing, as we
Right.
talked about earlier? So yeah.
I
Okay.
always I always recommend, like, once a new medication is started, there should also be a plan, like for me to use and end use, like you like it just cannot be let's start and then let's keep refilling, renewing. And there should be a plan in place.
Mhm.
And it may not be a plan that will be executed by the initiating provider. But one thing we know is when the patients do change providers, I'm almost sure like the medical records also changes, like also gets moved. Hopefully the notes are still intact to be able to like they can see it. Or if the patient is truly involved in that care, like, communicating with the patient, that patient should, or at least a caregiver would be engaged enough to bring up the initial plan with the new clinician. It comes
Mhm.
out to just involving the patients too. Some patients would like to be involved as much as we don't think they do. They really do, patients and caregivers alike.
Mhm.
That's so interesting that you you talk about that plan piece. Like there's been some recent articles that have come out related to specifically benzodiazepine utilization and a lack of plan, oftentimes leading to extended periods of time, people staying on medications that are designed originally to be a shorter duration therapy, right? And we see that so often, Ahunna. I'm curious if you have some, tidbits in here, then no worries and no pressure. I know you're on the spot live. But Don and I have talked previously about things like proton pump inhibitors like omeprazole, right? Things that get on oftentimes in the hospital for some folks and get left on for a longer period of time. Other guideline changes that there are medications that were previously utilized that no longer are part of those guidelines or don't show a whole lot of benefit, don't get pulled off, unfortunately on that side of things. But here's the thing, I'm going to throw you a little twist in there. How has it been to work with the patients and their thoughts, their cultural beliefs when it comes to what do they want to get off and how do they want to get off those medications and what tolerances do they have? Easy to look at a list and say scratch, 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 and they're
Right.
gone. Much more difficult to do that in a live human being that has feelings and family and other responsibilities in life. What have you encountered there, and what kind of lessons from this patient advocacy mind that I'm staring at?
I think absolutely have to get the patients involved. The patient has to have a buy-in in whatever the plan is. And it cannot be pushy, right? We understand how these medications work, especially medication that can cause dependency. So we know that there's likely anxiety surrounding that idea when it's brought up. So we also have to respect that for the patient. So listening to the patient and having a conversation, making sure they get the buy-in. And if they're not ready to make that change, maybe you can wait and then bring that up again. But the patient would have to understand, for me to get you started on this or for you to remain on this, we have to create a plan, because I want the best for you. And I know leaving this off the table is not the best for you. So on the patient advocacy end of things, getting the patient buy-in, crafting a nicely done, clear message to the patients on the steps you think or plan, and seeing how it resonates with them, and then ask for their feedback. Where can we make changes? What do you think? Should we do this for a little longer than, like, a little more, instead of 4 weeks, do it for like 8 weeks? Yeah, we can do that. Just it helps them like be in tune with you on whatever plan you have for them.
Love it.
Right.
Yeah.
But if we do it the other way, I say, well, we're gonna do this for 4 weeks, and after that, I'm not writing anymore, blah blah blah, all that stuff. Right. Like, it doesn't accomplish it.
Paternalistic medicine has been difficult for way too long. We just haven't admitted it. And I love that you incorporate what's called shared decision making, right? That you give options and allow those individuals that's their lives, that's their medications they're taking, to make some decisions, not only on what treatments to get on, but how to get off of them. And I think that's a brilliant nugget to go there. The only one I want to pass it over to Donna next, but I wanted to plug in real quick. What technologies right now, Ahunna, are you using for patients to be able to help them with some of these reviews, to keep up with their medications, to increase overall adherence, and obviously just to improve their clinical outcomes? What things are you using as both an independent and a consultant pharmacist so that patients can be more successful, on their own?
Well, on the pharmacy side of things, we use our pharmacy software, and we encourage the patient to actually to create an account. So it's not just about knowing the RX numbers or knowing what medication, like actually creating the account allows them to visually see what they're taking. So that way they're a little more engaged into their own care. And I know that's HIPAA protective. So that's really been a lot. That's been very helpful because in that way too, they can always send us a message about any of the medications that they want or that they're not clear about or any inquiries they have, and without having to worry about the HIPAA violations. And then on the consulting side of things, if my provider, well, for my providers that I have access to their EHR, same, it's all protected. And then for those that I don't have access to their EHR, they can always call me directly or send me a message, but no patient information whatsoever.
Sure.
Yeah, so like again, subscription based, they're different tiers. And if that's the preferred method, we cannot discuss any patient information, no birth dates, no sensitive information and whatnot. Right. But maybe when things get better and if I scale a little more, I can have something a lot more HIPAA protected.
There you go. We'll talk then.
Awesome. That's great. So just curious in general, you mentioned that you're a preceptor too, and just think about the different folks you engage with, a lot of interprofessional groups going on there as well. So thinking about not only your students, but all the different interprofessionals that you work with, what are some of the things that you see moving forward, and what would you tell a new pharmacy student to be trying to do with their future career in order to, to do what you're doing and making people feel good and better and healthy and being that person for them?
Well, I always, with my students, and when they see what I do, my biggest takeaway message for them is always just to remember going through this whole pharmacy school, whether after pharmacy school or going into residency too, just the point is to be able to not perfect, but be comfortable with the pharmacy knowledge and medication knowledge, right? And how they use it is where the difference is done. And they have to start thinking, and I don't care wherever they end up, community, retail, wherever, they have to start thinking that pharmacist as it like can also work in a service-based industry with this knowledge. Mm-hmm. They just, you just have to, because when we look around other healthcare professionals, you can't just reach out to them and grab the knowledge from them and just keep going. Like, it's all service-based, but sure, you can also have product-based, but that service-based execution of your knowledge is so important. Like moving forward, we have got to stress it. And I try to tell my students, and I don't even have a whole lot going on. I see a lot of other pharmacists doing great things. And I encourage them, network, get to know these people, learn from them. I mean, people are sharing information, start building out a way that you can use this knowledge that you're building on to get more impact, as a professional once you're done. And I also encourage them to try and build relationships outside of pharmacy. I feel like whether we try it or not, pharmacy is so connected. You know someone that knows somebody from somebody else, right? So you don't have to try to build a relationship in pharmacy, but you've got to try to build a relationship outside of pharmacy. You actually have to, and everyone is just trying to figure it out. So go for it and stop being afraid of what could happen. I was there, and now what do I have to lose?
Right.
Speaking of everybody trying to figure it out, that's my last question, is exactly what Donna asked, but from the patient side. Really trying to see, you're a patient trying to navigate things in this crazy medication world, right? Where do you start? Where do you go? Like what things would you emphasize to them to if they're working with mom and dad, if they're working, helping themselves or another family member, or they're advocating for colleagues, whatever the case may be, where should they go? What should they do?
On the patient side of things, is the same. We have to teach our patients to unlearn what they think pharmacy is. And initially, you have those patients that will say, "Oh no, I'll talk about it with my doctor," or "Oh no, I think my doctor already has it covered." And then you have the patient that will call you from their doctor's office and say, "Oh, they're saying this and that, like, they just stepped out. What do you think?" Like they're asking. It's a mess, right? But we owe it to our patients to help them unlearn that pharmacy is not just where you go when you're sick to pick up the medication. Oh, here's more drug. That should be better. No, we have to teach them to also understand that pharmacy is no, that's too much drug. Stop. But then I have people that tell me you've got to be careful saying things like this because you're going to go out of business. No one is going to need the medication. And that's not true. We're always, people, you're still going to have a cold, things happen. But if you keep taking all those things over and over there, I don't want it to harm you. I'd rather you hang tight with me for a little longer than, and, get hurt by a medication that you're taking. So it's just helping our patients to unlearn how they view pharmacy and what pharmacists can actually do for them. Because I think if we also can get them on board and they understand that most of our patients, they'll be having those type of conversations with the other providers. And guess what? You've made an impact with their other providers because then they're like, oh, okay, well, I will see. And the dots will be connected. We're all a team. Yeah.
Mm-hmm. Great.
Awesome. Well, that's perfect. Donna, any last questions or anything else for Ahunna? I just really appreciate you, Ahunna. Your view on patients and making sure they're prioritized is very refreshing.
Absolutely. Yeah. Thank you guys for having me.
Yeah. Ahunna, I just want to say, like, you do have a few different businesses, all kind of tied into one, right? But really amazing with the pharmacy, Southside Discount Pharmacy, and also with Aligned Care. Just great things. And I believe that there's one other one, like My Pharmacist or something.
That's
too,
part of Aligned Care.
Oh, Aligned. Okay. Thank you for clarifying that. So, so please let us know, like, please tell everybody how they can find you, and in these programs.
Absolutely. I'm always on LinkedIn. No, I schedule my posts, but yes, you can always reach me on LinkedIn. Send me a message at any point. That DM is always open, and I like meeting new people. I mean, in that era of my life that I want to know, like, however I can help, let me please help. Or if you can help me, please help me. LinkedIn is the best way to connect with me directly, or you can visit any of our websites, SouthsideDiscountRx.com or AlignedCareLLC.com. That's it.
Oh, that's perfect. No, that's not it. I'm sure there is more to come from Ahunna. I can just sense it. And hopefully the kids and husband off stage will be ready to jump into the ship and start rowing with mom, because that's an important family business effort there. Ahunna, thank you so much. I've just really enjoyed the conversation. The nerves were not there at all. You were just very genuine and very enjoyable the entire way. Hope the audience enjoyed it and really got to see a pharmacist that cares very deeply about building relationships in a community, building them both with the clinicians that she's working with and with the patients that she's caring for. And I think that's something that we just need to understand to a deeper level, that we can have that kind of service. We should expect that kind of service. And without any further ado, thank you guys so much for another wonderful episode of the MedList. And we hope you guys join us next time. Facebook, LinkedIn, YouTube, Apple Podcast, Spotify. I think those are the spots right now. So we'll see you over there.
Thank you. Bye.